changing gears a little bit, as we're talking about acalabrutinib and ibrutinib, what about, ibrutinib has a much more long-term follow-up at this point. It's an older drug, it was the first to market, and acalabrutinib is a much younger sibling or cousin. So what are the data for the long-term follow-up in ibrutinib?
Right. Well, the longest term follow-ups actually from the phase 1b/2 study, single arm study, which is out to about 7 or 8 years now. And at that point in the relapse setting, only about 25% of patients are still on drug. The median PFS was about 50 months, 4.5 years overall. Shorter in 17P, where it was only about 2.5 years. Shorter in complex karyotype, where it was about 33 months. The 11Q patients were about at the average for the population. And there was a small frontline cohort on that study, only about 30 low-risk patients, but their PFS is still quite high, above 90%, although most of them, or about half, are off drug, mostly for various toxicities, which we've already discussed, and we can discuss more, that tend to accumulate in patients on ibrutinib for a long time. The first randomized trial was Resonate, and that now has more than 5-year follow-up. But the median PFS was reached some time ago at about 44 months. This was a relapsed population with 2 to 3 prior therapies, and about a third of them had 17p deletion, half had p53 mutation. So a very high-risk population. That's obviously a very nice PFS for that randomized trial. We don't have that kind of long duration data with acalabrutinib, certainly not from a randomized trial. Those are only at about 2.5 year follow-up. And so that is an issue. It influences me more in drug selection for the higher risk patients, the 17p patients, for example, or even obscure things like PLL. People who you're more worried about, if there's longer term data, it provides some comfort. Although I feel pretty comfortable that acalabrutinib is a highly effective drug still. And so I'd be more influenced about the age and the comorbidities and still be willing in many cases to choose acalabrutinib. The other issue we should just address is I think that some docs have had the idea maybe you can treat people 6 or 12 months with a BTK inhibitor, get them in remission, and then stop. You know, maybe the cost is too much, maybe the patient has a minor side effect. And, you know, I never do that. That's just not a good idea. Patient's disease can flare, it can breed resistance, so they might lose the ability to go back on the drug. And it really can't be recommended in my view.
Yeah, I agree. We know that, you know, there's selective pressure there, and the main issue with resistance with BTK inhibitors is the acquired BTK-C481S mutation, and it seems that patients who have interruptions of the drug may breed a little bit more of that. I mean, it's driven by the use of BTK inhibitors. It's usually, you don't find these BTK mutations in general pre-use of the drug, but I do fear that it will drive more resistance as well. And accordingly, with this stop and go kind of approach, which there's no data to support, also there's no data to support as of yet, reducing the dose off the bat with Bruton by seeing people starting with 140 milligrams and trying to build up afterwards. It's not the indicated dose. You only should decrease that if there is CYP3A4 interactions, or do the opposite. You start at the right dose and the patient have significant side effects. There's a whole algorithm on how to decrease the dose based on that. We do know that it's important to front load the dosage and try to have the significant BTK inhibition off the bat, and has less detrimental issues in terms of efficacy down the road if you decrease the dose based on side effects. Of course, there's data from MD Anderson doing the full dose the first month, it's phase 1, and then decreasing the dose afterwards in terms of BTK inhibition seems to be stable. But I wouldn't favor the opposite, which I've seen a number of doctors doing, and that can drive, you know, different outcomes for those patients. So in terms of, sorry?
I've seen that as well, but I have to say, I still try to resist reducing the dose even later. The MD Anderson data is favorable, but it was based on about 10 patients and there's no clinical outcome, right?
Yes, it is.
I really
just
think
based
what
on
we need is a clinical test for BTK occupancy so that we can actually titrate the dose to a particular patient's need.
Yeah, I agree with that. I mean, it's a preclinical data, quote unquote. I mean, you have few patients, it's more on how the BTK occupancy occurred there.